had segmentation installed in our clinical system for about 12 months. Initially, we got segmentation in to look at our triage and how we managed our on-the-day capacity, to try and improve how we flex the system based on seasonal demand or, holidays and sickness within our clinical team, which has obviously made a massive impact on the day demand. But I think one of the things we didn't really envisage how it worked initially was being able to use sort of case finding reports to find patients that were higher risk for admission. So predominantly, I think we use it quite similar to other practices with our sort of e-consult tool, where we use it to segment our patients into red, amber, green based on their sort of health needs and how they are in our clinical system. And then we sort of use our triage tool to further segment them and triage them based on their condition on that day. We're quite predominantly clinical based here, so a lot of our triage is done clinically. So we use it to sort of give us an idea of the best person that might be placed with, or the best, service locally that might be better placed to help that patient. Probably the best use case we're using it for at the moment is our care planning. So before we had certain criteria where we would case find our patients, mostly proactively from seeing them clinically for other problems. But now we're starting to use the segments for the higher segments and actually how we can recall them in specifically for that condition. So people that wouldn't necessarily have been picked up on sort of severe frailty or age or number of presentations, actually we're finding a lot more patients with higher segments that weren't initially in that search almost. So our calls are down 27% month on month really from that 8 o'clock rush, whereas before on a Monday morning we could easily get 80 to 100 calls. Now we're getting 3 or 4 and a lot of that is through that triage system with it. So it's really helping to sort of workflow the patients and be able to safely push back from that urgent demand on the day to say actually this is going to be better placed with the clinician that you know best in 3 days time, or actually let's move you to another service locally that might be better placed to help deal with that problem. So it's a clinician, it's a paramedic or the duty doctor that's triaging that request. Although we would think initially the use case was that would allow us to have non-clinicians and reception teams to do that first pass triage, actually we're using it more for safety for us as clinicians. A patient that comes in, a young patient, fit and well, with a simple gastroenteritis, which we would then think to send to the pharmacy or to manage through our triage tool electronically without an appointment. But actually they've got an amber or a red segment, without actually even knowing that patient, without going into their tool, into the clinical system, we're able to say, actually, that's a red patient, why is that? And then we can then go and look that up closer and make sure that wasn't a wasted journey to the pharmacy and they've come back at 1 o'clock later that day. So it's improving the patient access, it's reducing duplicate appointments, and it's making sure that not only are we getting more amber and red patients in to see the right clinician, we're also making sure that green patients are put to other providers that might make it more suitable for that problem. Initially we had certain searches that we created or searches we'd found that had grown organically to bring in certain patients that might be our case finding for sort of say our care planning or our admission avoidance. And initially we had certain registers, so our housebound patients, our palliative patients, our MDT sort of list patients. Now what we can do is use our segmentation scores to bring in some of those more sort of amber and red patients that may not have even appeared in that search before. So for example, we might have patients that were the younger, that weren't having many hospital admissions, that didn't have a frailty score on traditional sort of EFI scoring tools. And actually now they're coming up in our searches to say, oh, actually this patient's a red 11, they actually might benefit from a care plan here, or at least some sort of regular touch points with some of our GPs or our other paramedic staff and things like that, which has been really powerful to find a cohort of patients that we didn't traditionally have. The first thing we want to do is start to try and use our triage model for non-clinicians as well. So it's still predominantly clinically focused and we're still going to have people doing that on the day, but to try and work out what type of patients we can, workflow through our reception teams and work as a triage team on the day. The second thing we want to look at is who are our red patients. Do they need longer appointments? Do they need workflow into different clinicians? can some of our green patients be reviewed remotely by our clinicians? There is so much data in the clinical record at the moment. There is data coming from every avenue, from A&E reports, from community matrons, from Pharmacy First. There's so much data and so many diagnoses that are coming through that sometimes just having that segment on your triage tool or in your clinical system draws your attention to something else. Every practice works differently, they've got different demands, they've got different demographics. I think what we've been able to do here at Burdwood is to, yes, we use it for our triage, yes, we've been able to safely make decisions on those acute presentations, but actually it's allowed us to plan our work better. It's enabled us to bring the right patients in at the right time, to give them longer appointments, to put them with the right provider, and that's really sort of helped overall to reduce recurrent appointments, to increase patient GP satisfaction. It's really helped.